I just thank the organizers, AIOS and Aladdin, for giving me this opportunity. It's indeed great to present in front of my teachers and seniors here. So my topic for the day is what not to miss in an OCT. And the intent of presenting this talk is not just to show the classical features of a retinal disease on OCT, but to show some characteristic features of on OCT of a few not so commonly seen retinal disorders, identify the OCT findings which can affect the visual acuity, and differentiate an OCT from similar looking retinal diseases. So as we've already discussed over the previous four talks, that the common features on the OCT for a diabetic macular edema, a non-tractional variety, is the presence of a cystoid macular edema, neurosensory detachment, and spongiform thickening. And the other OCT biomarkers which have been commonly discussed is the DRIL, the hyperreflective foci in the retina and choroid, the ELM and the ISOL layers, and also the outlet deep capillary plexus. You can very clearly see the capillary droppouts and the flow wide areas which are happening. DRIL. So basically, DRIL is disorganization of, there is basically a structural damage to the retinal inner layers and there is loss of parallelism. The outer retina is intact and it occurs mainly due to a damage to the superficial and the deep vascular plexus. So basically, there is a vascular insult to the inner retina, and the presence of a DRIL indicates a poor prognosis. Now let's look at this OCT scan, where on the left side of to the fovea, you can see that the layers are parallel and they are intact, whereas on the and also of the outer deep capillary plexus, you can very clearly see the capillary dropouts and the flow void areas which are seen on the OCT angiography. So what I wanted to say with this slide was that if you are suspecting macular ischemia in a patient with a diabetic macular edema, you don't always need to do an OCT angiography to ascertain whether the patient is having macular ischemia or not on the OCT angiography. Probably the identification of a DRIL and a disorganization is a good enough sign to say that there is a macular ischemia which is associated with it. The hyperreflective material in retinal and choroidal vascular diseases, we have spoken about subretinal hyperreflective material in AMD cases, but let's talk about them in, in DME. So this is a 57-year-old male who's a non-insulin dependent diabetic mellitus patient, visual acuity of 6 by 6, and he has got already got 4 intravitreal injections of ranibizumab, and he develops an intraretinal or intracystic hyperreflective material. And what you can see is that post treatment, so basically he's not been responding to the anti-VEGF, and post injection Ozurdex, he has shown a slight response, but there is a presence of a hyperreflective material which is present within the cyst. And this is a quite a rare condition. Even in this second case, we can see that this patient has had a very poor response with intravitreal anti-VEGFs, and he develops this intraretinal hyperreflective material. And post treatment with IVTA, you can see that there is a reduction in the size of the cyst as well as in the hyperreflective material. This kind of hyperreflective material, which we found in the intraretinal layers, can also be found in the subretinal layers within the subretinal fluid as well. And we published a recent paper where we described the intraretinal hyperreflective material in center involving diabetic macular edema as one of the poor prognosticating signs in diabetic retinopathy or DME. So the reason why we get this hyperreflective material within the cyst is basically because of three reasons. You can have you have this microaneurysm which are closely associated with the cyst. So there is a persistent leak from these microaneurysms into the cystoid space, which continuously keeps on leaking. These hyperreflective material are usually associated with discontinuity of the ELM and the ISOS. So there is a communication for the shredded photoreceptors to get collected within the inner retinal layers. So that is another theory which we are trying to put it up. And third is that this hyperreflective material is an accumulation of heme, fibrin, and hexudates, and therefore it's a mixture of hemorrhage within the cyst which is happening. So that is why it's a very poor prognosticating sign, and that poor prognosis could also be because of the discontinuity within the ELM and the ISOS layer which we have in such cases. So when we try to differentiate this hyperreflective material within the intraretinal space and the subretinal space, in intraretinal space, you get it in chronic cases of DME, where the inflammatory fibrin-like material is associated with heme. They usually respond poorly to anti-VEGF injections, and intraocular steroids are useful in such cases. Whereas when you get a subretinal hyperreflective material, They're usually associated with systemic diseases like hypertension and renal disease. They are seen in neurosensory detachment, and they usually a good systemic control of the nephrorenal problem and the hypertension helps in reduction of this hyperreflective material. And the visual acuity depends on whether the hyperreflective material is located underneath the fovea or not. So we also found this hyperreflective material in patients with acute BRVOs, where it is again a mixture of heme exudates and fibrin, and it is the location of the fovea at the fovea which decides what is going to happen to the final visual acuity. So this is a patient with the acute supratemporal BRVO, and what we found is that there was a presence of subretinal hyperreflective material in addition to the subretinal fluid. And when we treated this patient with anti-VEGF, the visual acuity did not improve much because of the presence of the residual hyperreflective material which got accumulated underneath the fovea. So we published this paper as well, where we said that there is this hyperreflective material which you get in vascular diseases involving the retina, such as in treatment-naive BRVOs as well. And that also indicates a poor prognosticating factor if it is associated underneath the fovea. So we all know SHRM has been classically described as type 1 or type 2 when it is above or below the RP. And presence of a SHRM indirectly indicates the activity of the of the membrane. So treatment has to be given when there is SHRM. Now let's look at other vascular disorders like MACTEL. So you have an ample number of features which you see in MACTEL and proliferative and in PFTs. So this ranges right from foveal thinning to inner retinal opacification, perifoveal hyperreflectivity of the deep capillary plexus, retinal crystals, degenerative cysts in the outer and the inner retina. There's one presence of pigment plaques, SRNBM, and the retinochoroidal or the retinal features on the OCT in cases of MACTEL type 2. And these are the cases which you see in the outer retina in patients with MACTEL type 2. And what is important is that when a patient develops this outward turning of this inner retinal layers towards the outer retina, that indicates that he is probably going into the proliferative stage of the disease. So we need to look at this more carefully. But there are some times when you look only at the hyperreflectivity within the middle retinal layers, and you may actually diagnose cases of MACTEL as PAMM. And this is something which I did during my initial years. And so I just wanted to put up this case where you had this hyperreflectivity on either side of the fovea, which you could see even in MACTEL, and you have this hyperreflectivity on either side of the fovea, even in a case of paracentral acute middle maculopathy. So there is a way how to differentiate between the two. So in in MACTEL, you will have the other associated signs like the ILM drape and the hyperreflective spaces. But what's important is that this hyperreflectivity in the middle retinal layers is not associated with underlying shadowing, which you see in a case of PAMM. So usually you will have a shadowing which will be present in a case of PAMM, but not in a patient with MACTEL. And then you can have this additive imaging techniques like a confocal blue reflectance, which will clearly tell you whether it's a PAMM or a MACTEL. Let's look at what is the role of OCT in vascular occlusions. So basically, it tells us the level of occlusions and it differentiates between the different types of vascular occlusions. It also tells us the severity of vascular occlusions. So let me just show you how it tells about the level of vascular occlusions. So in a CRAO, you will have a total inner retinal opacification. In a BRAO, only one quadrant of inner retinal opacification. Cotton wool spots are basically nerve fiber layer ischemic infarcts. PAMM is when there is opacification or occlusion which is happening above the outer plexiform layer, and type 2 AMN when it is happening below the outer plexiform layer. So these are the various varieties of vascular occlusions which you can have. But this is very interesting. This is the patient who complained of sudden decrease in vision, and he came to us within 1 hour of the complaint, and we did AC parasynthesis. So this is how the OCT was looking, where you were actually seeing the retinal opacification. You were seeing the retinal layers actually. You can see the parallelism within the layers, and there is not significant retinal thickening. So we initially felt that this is a patient who's going to do very well with just by doing a simple AC parasynthesis and gonio massage. But unfortunately, the next day we called them and did the OCT, and you could see that the retinal thickening, the opacification, and the parallelism all were deteriorating, and we knew now that the patient is progressing. So this is on day 3, where you can see what we you can see that there is a slight ILM detachment which is developing with the inner retinal opacification. The day 7, there is a full-blown ILM detachment. And at day 10, you have already seen that this patient has developed cystoid macular edema with a neurosensory detachment and is worsening. So what we wanted to show with this case is that what are the sequential changes which can happen in a patient with CRAO when you do an OCT at regular intervals. With resolution of CRAO, what we have seen is that when there is a resolution of the retinal opacification, it is the superficial retina which resolves first, and then only the middle retina or the middle part of the inner retina which starts resolving. And finally, you will have a total thinning of the inner retinal layers in a patient with a chronic CRAO. Blunt trauma, I just wanted to come up with these two important and interesting findings which we see in patients with Berlin's edema or commercial retina in blunt trauma. So this is in the A image and the OCT corresponding top OCT. You can see that there is obliteration of the optical space in the outer retina or between the RP and the photoreceptor layer. That is what we exactly see in a patient with acute blunt trauma. But as the opacification resolves, you can see that there is some irregularity which happens in the RP layer, and following which you can see these conical caps which are found, and that is what we described as the hyperreflective micro elevations in the RP and the photoreceptor layer. We probably gave this term what is known as the cone outer segment cyst as well. Another interesting finding which we found in cases of blunt trauma is bacillary layer detachment. This is a terminology which I recently came across, and it is basically the improvement in the OCT technology which allows us to visualize the split in the myoid inner layer and the ellipsoid outer layer. This term was described way back by Polyak in 1947, and it is basically a separation between the myoid and the ellipsoid components of the photoreceptor inner segment. So this is a patient with blunt trauma. He had a history of injury with a ball, and what you can see is, you can see with the white arrow, you can see that there is a split which happens between the ellipsoid layer and the myoid layer, and there is an accumulation of the hemorrhage between those two layers. So what this is not a subretinal hemorrhage which we commonly see and commonly describe on the OCT. This is what we described as the intrabacillary layer hemorrhage. And this intrabacillary layer hemorrhage, they usually happen because of the shearing force of the trauma, the mechanical presence of heme. There is a poor perfusion of the photoreceptors due to the stress and the separation of the photoreceptor layer, and also because of the post-traumatic inflammation. The bacillary layer detachment in patients with trauma is a very rare finding, and detachments, they usually with time they resolve on their own, and the hemorrhages they resolve, leading to an attachment of the bacillary layer. The intrabacillary layer hemorrhage undergoes resolution without showing features of dehemoglobinization, unlike the subretinal blood. So what we found is that the subretinal blood usually undergoes changes in the color, whereas the intrabacillary hemorrhage, it does not undergo changes in color, it just undergoes a spontaneous absorption. What happens with a myopic retinopathy? We describe this term known as myopic retinopathy, where there is actually foveal flattening, persistence of the inner retinal layers, there is a normal outer retina, and there is thinning of the photoreceptor layer. So this is what we described as the earliest change in cases with pathological myopia. And in addition, you can see some rare OCT findings like intrachoroidal cavitations, presence of a myopic sinkhole. So all these features are very, if you try to look for it, you'll start getting them in patients with tilted disc and pathological myopias. Posterior microphthalmos, a very interesting finding which we found in posterior microphthalmos was the presence of the retinal papillomacular fold. People have described it commonly, but what we realize is that the fold is not present in all the meridians of the scan. It is present only in a specific meridian of the scan, thereby suggesting that the shortening of the highball happens only in one meridian. There is thickening of the inner retinal layers, the outer retinal layers are intact, and in nanophthalmos, where there is a uniform shortening of the globe, there is no retinal papillomacular fold. So that is something which we found. Torpedo maculopathy, again on the OCT, is being described into three types: one with no subretinal cleft, the second with a cleft with inner choroidal thinning, and the presence of a choroidal cavitation and a CNVM. So this is one of our cases of torpedo lesions where we found a patient to have a focal choroidal excavation with the presence of a CNVM along with it. Hematocrit sign has been commonly described in patients with, they have been commonly described in patients with PCBs, but we described hematocrit sign in a patient with PAVAC. And this is something which you can see in the yellow arrow, which is present, where you can see that there is a layering of the RBCs and a clear fluid within the cyst. So this is something which we found in patients with PAVAC as well. In fact, it can happen with any microaneurysm or any aneurysm which are present in the retinal or the choroidal vasculature. Again, Enface OCT in lymphomas, you could see these white dots, which you can see in the deep layers, which are basically suggestive of the wide vertical hyperreflective foci, which you see in patients with intraocular lymphomas. And following treatment with intravitreal methotrexate or rituximab, there is a disappearance of these spots. Contact sign is basically because of a granuloma which is compressing against the RP, as a result of which there is exudate accumulation which happens and a neurosensory detachment. And following treatment with corticosteroids or with antitubercular therapy, you can have the reduction in the choroidal granuloma and the contact sign. Again, choroidal nevus, a very useful tool where you can see the shadowing which happens behind the nevus in the choroid. And also very useful to identify the presence of a CNVM in a patient with choroidal nevus, where the OCT angiography also helps us to identify the neovascular network. So this is a paper where we describe the findings of choroidal imaging findings in choroidal nevus with color fundus photography. So basically, to summarize, in all, the OCT is an extremely important imaging tool in retinal practice. The diagnosis, treatment, and monitoring of a particular retinal disease is based on the OCT, and it's very important to understand and analyze the OCT properly. Thank you so much.